Healthy.
This is a new series aimed at providing older adults with resources on health, fitness, finances, and other services.
Happy and Healthy.
Welcome to another edition of Happy and Healthy, a series that provides help to community connections to older adults and their families and gives them information on what's available to them. Today we're going to be talking about veteran services. I'm Louise Thompson. I'm the Executive Director of Tampa Bay Community Network, where you can come and learn how to do video production training and have your own show on about any topic that you would like. With us today are Dr. Hay Park, who is the Section Chief of Transitional Care at James A. Haley Veterans Hospital. Welcome, Dr. Park. Appreciate you being here. And Carol McFarland, a Social Work Section Chief, Geriatrics and Extended Care Programs. You guys got to shorten these things. James Haley Veterans Hospital. Appreciate you both being here. Can you talk to us first about what your department does or what you're in charge of? I'll start with you, Dr. Park.
I'm a geriatrician. I work at James A. Haley Tampa VA Hospital. The service that I work under is a geriatrics and extended care service. Currently, I'm leading a section called the Transitional Care Section, and we have a few programs where we oversee the quality of care for veterans who are transitioning between different healthcare settings. And our programs are designed to promote the safe transitions as well as avoid unnecessary healthcare utilization such as hospitalizations or emergency room use.
You keep their service from being disrupted.
That's right. So we try to bridge the gap between different healthcare settings and promote the safety as they are going through the transitions. So for example, patients who are going home from hospital after hospitalization, especially those who are more vulnerable to the adverse events due to their multiple medical conditions or functional impairments or lack of social support system. We try to provide a service where we could oversee their care transitions and fill the gap.
Carol, tell me about your responsibilities or department.
I am the Social Work Section Chief for the Geriatric and Extended Care Programs, and I oversee approximately 17 social workers in my program with different areas, which is medical foster home program. We do community nursing home program. We have the program, the transitional care program under Dr. Park. I work very in concert with Dr. Park, with those older veterans who access care. We have the home health aid program. That is a program that we have that if veterans are home and needing care, we contract with outside agencies to provide home health aid care for those veterans and caregivers. We also have a hospice and palliative care program. We have a consult team that throughout the hospital that helps with end-of-life care for our veterans, and we have a newly opened hospice unit at the James A. Haley Veterans Hospital.
And that's separate from a hospice agency. This is just
that's separate.
This
is under the veterans, and that's a new.
You just said 17 social workers.
17 social.
How many people are you taking? I mean, on average, do you handle? That seems like a lot of people.
It is a lot of them. I mean, we are a department, the social work department at James A. Haley. It's a department of over 130 social workers. And so, but we provide services to veterans of all era. But my program that I am the section chief for is the geriatric extended care programs.
Okay. Dr. Park, you just said that your program is new. They didn't have it for a long period of time, or a brand new model program?
Our specific transitional care program was developed about 4 years ago.
Okay.
And the programs that we have within our section is specifically designed to target vulnerable patients who are at risk of experiencing adverse events after hospitalizations or after stay at a community nursing home. because it has been shown that during the times of a transition, veterans, especially at-risk patients, have increased risk of rehospitalizations or going back to emergency rooms for something really very simple, like not having correct medications, not understanding the instructions, not being able to self-manage or follow up of their chronic conditions. So the transitional care section has the programs to oversee those types of veterans. However, within our VA, we also have several other programs that Carol has just mentioned, and I would like to bring out a few programs that have shown positive outcome in promoting safety as well as containing the cost and preventing unnecessary healthcare use. For example, a program like a home-based primary care was designed to provide the primary care, and it is an interdisciplinary approach where multiple disciplines of providers work together as a team to provide primary care to veterans who have difficulties traveling to the office or to the clinics. So we provide the primary care at home. Our providers make home visits. So it's like a primary care clinic that's accustomed to be given
it's
at
not
home setting.
24/7 though, is it? Or?
It is not, but just like the clinics, outpatient clinics would not provide 24-hour nursing care, but it would be very close monitoring of chronic disease and support of the patient and caregivers in disease management. This program has shown positive outcomes as far as improving patient safety and enhancing the health status.
Not as many rehospitalizations.
Definitely,
is that what it is?
Definitely, because the program specifically targets high-risk group.
What's a high-risk person? Could you describe that for us?
There are many high-risk factors that we could use from studies, but typically the patients who have multiple diseases, and there are specific diseases that are shown to cause recurrent hospitalizations, and those are typically congestive heart failure, like emphysema, diabetes, stroke, chronic kidney failure. So we could proactively target those veterans. And we know by looking at the track record, veteran who has had 6 hospitalizations last year, we know they're at risk of another hospitalization.
So you try to figure out why that rehospitalization
definitely
occurred.
And it could be various causes. It could be something as simple as not having proper living environment, not safe living environment, and being able to take their medications as instructed because there's no system set up at home.
Plus it gets confusing if you have lots of drugs.
It does, and especially if you have a veteran who have cognitive impairment, dementia, that definitely brings up the risk tremendously.
Is any veteran eligible for the range of services, or is it required that they had their illness or injury occurred when they were in service?
All veterans are eligible for our services. The benefits may vary, but all veterans are eligible. We do have a benefit department that help us to work with veterans when we have those questions. But in a broad spectrum, all of our veterans have some form of services that we can provide, tailored to their need.
I noticed on your website that if a veteran was more than 50 miles away from the hospital, that you provide some housing assistance?
Yes,
or
we do.
What is that?
We do have the Fisher House on site. We also have the Clarion that we have a contract with. So yes, if our veterans live more than 50 miles, we provide housing for their loved ones, their caregivers, to stay while they're in the hospital.
And if they're needing multiple days of service, that would be they would be
Yes,
eligible
absolutely,
for that as well.
absolutely.
Okay, so you're with us being in these recent wars, is there been a tremendous increase in the number of people that are looking for service?
Absolutely.
Especially economic downturns and all of that, I'm sure.
Yes, we do. And we have a tremendous amount of veterans who are seeking care at the James A. Haley Veterans Facility. It's a trauma facility, so we do get, we have all specialties there. So we do get veterans from all era.
I'm a little confused about, I right now have a relative who is going through rehospitalizations and has diabetes, renal failure, lots of things going on, and it's just been repeated. And I was not aware of the different types of services, like skilled nursing versus a nursing home,
Right.
versus, there's all sort of assisted living. Can you explain some of that? And
we have several types of settings. We have a model, they're called the medical foster home model. And this is it's a great model because we have veterans who can no longer live at home, or their caregiver is burdened and can no longer provide the care. And we have people in the community who are willing to take these veterans into their home and provide these care. And we monitor them closely. It's a team approach. Multidisciplinary team goes out to the home, make sure the home is safe. We make sure the caregiver the care is adequate for the veterans. We have medical foster home social workers who follow these veterans at home to make sure that the setting is compatible.
And the people who do this, are they compensated?
They are compensated. The veterans compensate the caregiver.
The hospital itself doesn't. The veteran.
No, we coordinate the care.
You get
we coordinate that
and you
care.
check out the people and make sure that they're capable of
absolutely
taking care of.
And we put all the safety measures in place. Make sure that the homes have alarms, and fall risk is a big. We take that precaution.
Maybe you could talk about that too for our viewers. What makes a home safer for someone with? I'm sure that there's different things depending on the person, but overall, how they can help make their home safer for someone who's ill.
Well, if we have someone who has a home, who wants to open it up to our veterans, of course our safety officer goes out and the social worker goes out. We have to make sure the home is wheelchair accessible. We have to make sure that there are handlebars in the bathroom and grab bars in the shower, and all those safety features that would focus on making sure our veterans' fall risk is diminished. So those are some of the precautions we take. Make sure fire alarms is in the home. And all those have to be put in place before a veteran is placed in that home.
So that's the benefit of a multidisciplinary and interdisciplinary approach in geriatric care. It's not just one provider who could make huge difference, but when they work together, patient safety is a great example. Patient safety could be related to something like medication errors, but it could also be fall risk. It could be somebody who doesn't have any access to emergency care or does not know how to access emergency care when there is an emergency. So when there's a multidisciplinary team with, for example, the medical foster home, when the patient gets enrolled into this program, our home-based primary care, which I had mentioned earlier, they automatically pick up the patient's primary care. Therefore, their team would be making a visit out on site to provide the safety assessment. And that will be done by multiple discipline again. So medications will be reviewed by pharmacists and the physician.
A good point, because that
right,
that
and
seems
the
to
bathroom
get
will
people
be
in
assessed
trouble.
by our
Absolutely.
kinesiotherapist to see, okay, is there an area rug that the veteran could trip over? Are
Right.
there enough safety bars to hold on to? You know, is the veteran able to get into the shower safely? Multiple aspects. That's how the multidisciplinary approach is
And I suppose the
beneficial.
social worker gets involved in talking to people about diagnosis, especially if there's some terminal
Definitely.
aspect to it. Or
Advanced care planning is one of
right.
the big aspect of the team approach. And we in VA, just like in the community, we do have our hospice and palliative care program where we provide arrangements of end-of-life care for our veterans with life-limiting illnesses. We also work very closely with our community partner, community hospice care programs, organizations to make sure the veterans would receive proper end-of-life care.
I saw something that said you even have a mobile, some kind of a mobile vehicle that goes out and does some care that way.
Yes, we
Can
do.
you tell me about that?
We have a mobile a van, bus, it's huge, that goes to different sites and do medical checks for some of our veterans who may live far away. And we have veterans who may not want to come on site to the hospital, so we go out in the community and try to provide the care that they need, and that is staffed by a physician and nurses
And
how
also,
far out do you go with, because I know I read stories some time ago about people who live in very small towns or in agricultural communities, and there isn't a VA hospital anywhere near them, and they have to go, I don't know, 300 miles to the one that's the closest. What happens with that?
Well, we go where there's a need. We have several community-based outpatient clinics, so we typically don't have a veteran who lives so far out from the James A. Haley VA that care cannot be accessed. However, you have some little rural towns, and we go where there's a need. Wherever the need is, that's where we go. So if a community-based outpatient clinic is not close by, or they're not close by to another VA hospital, we will go as far as we need to go to provide the care that is
Now,
needed.
James Haley also operates, besides the one in Tampa, this big one, you have other satellite.
we
Yes.
have the community-based
Clinic.
outpatient clinics.
Where are they all? They're all around.
There's one in Brooksville, there's one in Lakeland, one in Newport Richie,
So you're in Pasco, Pinellas,
and one in Zephyr Hills.
Zephyr Hills is Pasco
Yes.
County too, right?
Yes.
So you did do outreach. Plus, have I heard that the one that's here in Tampa has plans for expansion as well? Or is that down the road?
We are expanding, but I'm not quite sure when.
Okay.
Yeah. When the ribbon cutting will be. Yeah.
Depends on how the budget talks go, right? Is that right? Who knows?
I don't know about that part.
Where do you see some needs that we still have to deal with our veterans? I mean, that's always a concern of everybody's, I think. You know, we all regard our veterans as important people to our freedom and democracy, and we want to make sure they're taken care of.
We will continue to provide community outreach. We do have outreach coordinators who have gone out to the community to provide outreach. We have veterans who, for some reason, just will not come on site, so we provide those outreach to them, get them registered, get them enrolled in the program, making that access easy for them. We have online easy access enrollment sites, so we've made a lot of it
So
available.
they can get online.
So they
and
can
do
get
it.
online.
I was recently at a conference about women veterans who are homeless.
Right.
What can be done? What is being done?
We currently have a homeless program that we are very actively involved in. We have a coordinator, we have several coordinators in those programs. We're reaching out to our homeless veterans. We are doing what we call stand down, where we have gone to parks or wherever we think homeless veterans may be. We go on the bridges and we talk to them at 3 o'clock in the morning, if that's what it takes.
Oh, really?
To get them enrolled in the VA and to get them the resources they need. We work very closely with some of the shelter facilities so we can have contract for beds for our veterans. So we are doing just about a lot to make sure our veterans are not homeless.
Is this somewhat a why the transition program too? Another reason for it? Because these are people who didn't even know they had service, or perhaps they had some trauma from a war or what have you, and so they don't know how, they're not, they're cognitively impaired?
Right. Population aging has been long talked about. VA veterans population has outpaced the general population in aging. So in about 30 years, over 50% of veterans will be above age of 65. And we're trying to be proactive and design system and healthcare models where it is veteran-centered and it could be tailored to the needs of each veteran, and the transitional care would be a part of it. A very good, excellent care at one site, and there's very good care on another site. If they're not connected, if the dots are not connected, all the goods that has been done over here may not all be transmitted to the next site, and that ends up with the veterans or patients trapped in the revolving door of the hospitals. And we want to prevent that. And it may be my personal bias, I'm a transitional care person, but that's a huge emphasis at this time. And currently we have what's called patient-aligned care team in our primary care clinics. It's a new concept where we're all going to provide our primary care as a team, and the patient is in the center. It's not we're the center and they're coming to us. So all our ambulatory care clinics have changed its paradigm and embraced the concept of patient-centeredness, and transitional care is part of it.
Does that require their records to all be centralized so that no matter what department they're visiting, you could, and I don't know if you've done all that, but I've been out to the Cleveland Clinic with a friend of mine who's a patient there, and they have all their records centralized so that no matter which doctor you're going to for whatever, everybody knows where you've been, what medications you've been on. And
that is the blessing of electronic medical records, and VA has been a pioneer in implementing electronic medical records. We had it before anybody else, any other organizations out there had it. Therefore, within the VA system, if there's a veteran who comes to me from Hawaii, I could access their records, and I know what happened last month. So that's how good it has become. As far as organization to organization, probably is an area for the future. For example, VA to non-VA sites.
Right. Now that you mentioned as well that there not only is the regular population, non-veteran population aging, but what you just said about the veteran population outpacing the percentage. Are you looking into more foster models or foster home models, or other? Will there be a need for something more long-term than what we see now?
Absolutely. We are currently expanding the medical foster home program and the home-based primary care program. We're currently expanding that. We're currently expanding our skilled nursing facility so we can accommodate more long-term veterans if needed. So we have recognized the growing need and is putting things in place to contact when that need comes, then we have the resources to provide those care.
Are there some areas that we didn't cover because we're running short on time pretty soon? And just want to make sure that if you want to talk to our viewers about a particular area, that you have an opportunity to do that. Carol, go ahead.
We also have respite care for caregivers who are at home
that's fabulous.
and feels burdened with caregiving needs. We can provide services. We can provide it either at home in their home setting for up to 6 hours per day. They get up to 30 days per year. We can provide 6 hours at home at a time, or they can come into our skilled nursing facility for up to 14 days. For respite care.
So someone can go take a vacation who's been caring for a veteran.
Absolutely. We just have to coordinate it with us, because we have to reserve the bed and all that kind of stuff. But we do provide those services to our caregivers because we recognize that caregivers who are burdened, it's difficult to provide optimum care.
One
Dr.
program
Park?
that I am very proud of within our system is our telehealth program. It's a high-tech program. It's a care model. It's designed to provide ongoing close monitoring of chronic diseases in patients, outpatients, and by utilizing telehealth technologies. Patients would be able to enter their blood pressure, blood sugar, their oxygen saturation, daily weight into this device. VA receives the data, we interpret it, and we monitor the trend. We take appropriate proactive actions to prevent them from having exacerbation of underlying conditions and be able to support them, self-manage their chronic diseases.
The patient himself or herself
It could
inputs
be,
the data?
yes.
Or they're wearing,
Or their caregiver.
Or they're wearing something that's going to electronically input it, or?
It's a device where you could enter your data. So you will do your own blood sugar and blood pressure, and then you will enter the data.
And somebody on the other end looks at that and says, hey, we better get down there.
Yes, so if my veteran all of a sudden gains 5 pounds of weight and has diagnosis of heart failure, they will notify me. So I know that they're gaining weight, and wait a minute, is there something going on? Is he taking his medicines? Has he had a change in his diet? So that's a very proactive approach, and we're very proud of our telehealth programs.
And that's working out. People are taking part in doing this.
Definitely. Another good thing about it is, you empower the
But you're making them
patient.
more aware of themselves, too, and what's going on.
Definitely.
Because is that something like daily or weekly or something?
It could be done. I mean, the frequency could be decided based on the needs, but mostly we would monitor daily.
It also promotes independence, make them feel independent, that they're in control of their needs.
Very quickly, I know we're running out of time, but you also have plenty of mental health help, don't you? Because that's what we hear about the most, the post-traumatic stress and this kind of thing.
We do have a mental health
component.
We have mental health providers that goes out to our veterans. We also have the clinics that we have, our mental health clinics, and we also have the inpatient mental health unit that our veterans can access.
It's wonderful. I really appreciate both of you coming down and explaining some of the services, such a wealth and range of them available to our veterans. And I hope our viewers, your phones ring some more and they go visit your websites and so forth. And thank you so much for being here. Thank you for tuning in. And we'll see you next time on Happy and Healthy.
Getting health information is a nightmare.
It's all in how you look at it. To you, it's a pile of books and reading until your eyes drop out. But to me, I go straight to NIHseniorhealth.gov, click on what I want, and boom, there it is.
NIHseniorhealth.gov, the medical website created with older adults in mind by the National Institutes of Health.
Getting health information at our age is tough.
Yeah, it's all how you look at it. To you, it's a pile of books and reading till your eyes drop out. But me, I go to NIHseniorhealth.gov, click on what I want, and bingo, there it is.
Well, thanks for the tip.
NIHseniorhealth.gov. It's easy to use. You can make the text bigger, make the contrast better, even make it talk to you. If only everything else out there were senior friendly. NIHseniorhealth.gov, built with you in mind.